All right. Today we have Sister Gail from Johannesburg Infusion Center. Guys, I always say, please consider doing IVs, not only cosmetic IV, but a medical IV. Today we're going to hear a lot of benefits that comes with medical IVs. You know, hospital at home services, those patients that goes home with the antibiotic. Welcome, Sister Gail.
Thanks, Sister Marie.
How are you?
I'm great
Good.
and considered a great privilege
You're
to
back,
be here.
man.
Yeah, I'm here.
Yes. Yeah.
Yes,
Fresh and...
Yes, I'm definitely fresh after, the event we had in Limpopo with the charity.
That was amazing.
Amazing event.
And I just want to thank you, Kay, and everyone, the team. Hi, guys. Can I actually thank you? Because you know what? It was an amazing... We had an event at our Block 8 in Limpopo.
Yeah.
Part of the activity that we have in the NBS is to give back to the community, you know. So we've got a donation drive that we are doing program, and then we have identified a school in Limpopo where we have donated about 100 uniforms to children, obviously from underprivileged family. You understand, families, yeah. So, and also on that, Kay, I want to acknowledge. I always say that since I came back, I'm busy acknowledging the companies. People must not get tired of this because this is amazing. We want to send love and acknowledgement to companies like Shosholoza Finance. We Sunbake, they were there. ShopRite, ShopRite, we didn't even invite them. They just came, they just saw me on TikTok on one of the video and they came through, It was so amazing. And we had a present of our legend in Limpopo, Kin Munada. Thank you. Shout out to Kin Munada.
Shout out to Kin. What an amazing performance.
The way he interacted with his fans, it was amazing.
Spectacular.
Yes. And then we had Sister Ntombi. She's a PNP. She owns clinics, 3 clinics, Breaths, Lechabile and Mabopane.
Yeah.
So she's a very big wound care specialist and she does all other services. Her clinic is actually comprehensive. Yes. So she came with us. She drove all the way from here to Limpopo. Nice. We were so happy to see her. We had, what do you call those guys that were taking care?
Houses VIP protection. Yeah.
We had VIP protection, Yeah, but they
Definitely.
did well, hey?
Yeah.
Just imagine the crowd, those babies.
I can imagine, yeah. They were overwhelming.
Yes. And
you should have came through by now.
Yes. It's my home ground. There.
You know why? Yeah.
Wow.
You know what? Messina.
Is it?
Wow.
Okay.
So I know the area very well. Yeah.
That's prominent. That's nice.
Yeah.
Next time you're coming through, right?
Yeah, I know the area very well.
Next time you're coming through.
I want to touch on that, Kay, because a lot of PNPs that actually saw the videos, they approached me and they said next time they want to cause traffic. They want to come. Next time I must tell them when we announce another school, which I think we'll do at the event, maybe we'll have a school in Johannesburg. We're busy with allocating and selection of the appropriate right school that deserve to be donated, So we will have a lot of registered nurses, not even registered, all nurses, anyone in the healthcare professional. Guys, let's show another side that is not aligned with health, right?
Exactly.
To give back to the community, Yeah, so I hope I did not forget anyone, Kay. Can you remind me? Creative media
was doing great.
Yes.
Sound guys were great. Everybody was great. It was an amazing event,
Yeah,
it was perfect.
Ackermans Mall of Africa.
Yeah.
Oh, Shem, they did the most because they had to go through Ackermans and getting all the uniforms according to the list that we've provided. But anyway, thank you so much. Coming back to the initial...
Sister Gail.
Yeah.
Yes.
Okay. How are you, ma'am?
I'm good.
How do you feel?
A little bit nervous. I've never done a podcast before.
Oh, okay.
I don't have a problem with public speaking.
A little bit nervous? The person you were behind the camera? What happened to that person?
No. I don't have a problem with public speaking, but I've never done a podcast.
Wow.
So, yes.
Wow.
So
this is new for me.
You've never been in front of cameras? Like...
when I was a flight nurse, we did an episode. And when I was a trauma nurse, we did an episode for TV and that kind of stuff. But that's doing your job,
Okay.
Yeah.
This is more formal, I guess.
Okay.
Yes.
Okay.
Yes. Yeah. Okay. Sister Gail, I have been talking about a lot. Recently, I've been mentioning a lot about IV at home, IV therapy in the clinics, IV therapy post-hospital. antibiotic. People don't know about that, and I believe your as per your practice name, Johannesburg Infusion Center. So that means to me you deals with infusions,
mainly infusions.
Okay.
Yes.
Okay.
Yes.
Before we go there, tell us about yourself.
Yes, I was actually trying to work out how long I've been a nurse, and I think it's about 32 years now.
Wow.
So,
What?
yeah.
Almost my whole life?
Okay. I'm not sure if that's a compliment.
Yeah.
Yeah.
But you look good, hey?
Oh, thank you,
so
Maureen.
good, yeah.
Definitely. How old are you? You don't have to
Do you want
answer.
to ask that question?
You don't have to answer it.
So, I've considered myself very privileged in my nursing career because I have worked in many different arenas.
Yeah.
I worked in Botswana when that still existed. Very rural.
In Botswana.
Botswana. If you don't know if you remember Botswana, that's before your days.
Okay.
Wow.
Okay.
Yes.
Yeah, no.
Was one of the so-called homelands or whatever
Okay.
in the previous government, and I worked there, and it was the most amazing experience. I worked with Tswana nurses who taught me how to deliver babies in the most difficult situations, minimal water, no electricity. I developed a huge respect for the old Tswana nurses, and I think that was a big foundation for me in nursing.
Oh.
And I've worked rural areas for many years, government, and then
A little bit of a question before you continue.
yes,
You worked in the old government,
the old Botswana.
Tswana government.
Yes,
Oh,
Botswana. You guys don't even remember these things.
What are you talking about? Because
long time ago.
okay.
So because I wanted to work rural, always had a passion for working in rural areas.
yeah.
That's that passion, because rural is somewhere where people run away from. Where would the passion for you to actually put yourself where people are running away from come from?
I'm actually not sure. I think it's also maybe because I grew up in a smaller town and my mom was a nurse, and I realized the impact of nursing in these smaller towns. And also, and this is terrible to say, but when I was growing up, there was segregation between black and white.
Okay.
And my mom always worked in the black hospitals. It's terrible to say it, but that's how it was in those days. And I grew up running around those hospitals, and that was my passion. So that's where my mom worked, and that's what I wanted to do.
Wow.
So, yeah.
Well, even in the rural area, they deserve the best
Definitely,
quality nutrition.
Yeah.
So
It was a big foundation for me, that. And so I worked rural for many years, and then I came to Johannesburg. I had a passion to be a flight nurse. So I'd first done my postgraduate qualification in trauma and emergency nursing.
okay.
So I then managed a trauma unit for a while, and then I started flying.
Nice.
And then I was a flight nurse, and that was an amazing experience. I flew all over Africa, through over the world,
Wow.
fetched patients, moved patients, an ICU in the air.
Okay, nice.
How does that work? Is it hectic, or sometimes you're just cruising through the area and nothing happens?
No, so you must remember South Africa is considered a center of medical excellence in Africa.
Yes.
And Africa,
Yes.
and Africa
Got
is
very good
full of
hospitals here.
expats from all over the world. So if you were from, I don't know, Portugal, working on an oil rig, and you had a stroke, you would need to be evacuated to a center of medical excellence. And so we would evacuate you and bring
Was
you
it
down.
through government?
No, it was a
Okay.
private international company.
Okay.
Yes.
All right. Do they still exist?
Yeah, very much so.
Okay.
Yeah, international SOS, very much. And
How prominent are they now?
pardon?
How effective are they now? Are they
They're
bigger
massive.
now?
They're all over the world.
That's it.
Yeah. So if you ever go traveling and you buy your ticket on a credit card, you get medical insurance.
Okay.
And then you have a company that's in the background that should something happen to you, they've got to move you.
It's another topic. This is a big one because I'm very much interested. I run an agency, placement of nurses. I mean, I would love to have my nurses.
You know what I mean?
So it's
So?
very, very specialized. So as to become a flight nurse, you had to have all your advanced qualifications. In my case, trauma and emergency nursing, ACLS, PALS, ITLS, the whole toot. It's very advanced.
Yeah.
So, and you've really got to know your stuff because you don't have the backup of anybody else. It's you and the doctor on the flight. You've got to manage the patient.
So was it any flight or you had your own flight?
But we have our own, and they still do have their own aircraft
Okay.
that have specialized stretchers and that in it, small aircraft, jet engines. Yeah. I also helped setting up a company called Air Evacuation Services. They're still going now. I loved flying. Flying was a big passion for me.
Yeah.
Yes.
Yeah.
Yes. So I got
Traveled the whole of Africa.
I got to see a lot of Africa.
Wow.
Okay.
Very fortunate, very blessed.
Your favorite country?
Probably Zambia.
Wow, is it?
Yeah, love Zambia. But
Nice.
I love Zambia.
Okay.
Perfect.
All right.
Zimbabwe is also a beautiful country.
Okay.
Mozambique, very hot.
Jeez, can imagine.
Flew a lot to Nigeria, a lot of places in Nigeria.
Wow.
Yes, Accra, Ghana.
No, I think we talk with the game
So I had
to see if we can empower our nurses
Definitely.
and to expose them, because I think we are actually isolated. You know, a lot of these services, to me, I've never thought it's this big. You know, I know of the ship nurses.
Yes.
And then I also know.
So International SOS also oversees a lot of the ship nurses as well. There's a whole division in there. Nurses go work on oil rigs. And I think that's an interesting thing. And I know it's not what we're supposed to be talking about today, but I think many nurses don't realize how broad their scope of nursing can be.
Yes.
And I've been one of those very, very fortunate people to work from the most rural areas where we had no water, no electricity. I'd have a Tswana nurse, this baby's breaching in front of me. And I'm like, I don't know what to do. And she says, don't worry, my dear, let me show you. And this old Tswana nurse would deliver a breech baby by candlelight.
What? Yeah.
So I have a very good idea of what lack of services in South Africa is.
Yes. When they say you improvise,
and then
make things work.
Yeah. So then I've gone to the other extreme I was the chief flight nurse of an international company's aviation section, and I presented all over the world. I presented papers. I challenged the American flight nurse exam and passed it without studying. It was quite amazing. Yeah. So I went from the most rural to nothing, to going to this internationally accredited.
Wow.
So very, very, very fortunate. No, I consider myself privileged and fortunate.
Yeah.
But for that reason, I think I truly understand what lack of medical services for a certain group of clients or patients in South Africa really means.
Well, to brag about that as well, I got to experience the flying as a nurse to go and get some organs, because I was part of the liver transplantation in Donald Gordon.
Okay.
And then I was part of the team. I was the coordinator, and I'm the first sister or scrub sister who went with the doctors, flew with the doctors to go get organs for our harvest, for our liver transplantation.
Wow.
Yes.
When was that?
Just before I started my company in 2020. Yeah, recent. I think in 2022.
Wonderful.
Yeah, we would, it was in South Africa. We would go to Durban, Cape Town to get some organs to come for the transplant. Yeah. So it's a nice experience, you know.
Yeah.
It's a nice and amazing. It's like in the TV, it's like in the movies, you know. Yeah, because obviously you've got your red cooler box. Everyone is waiting. Remember, it's an overwhelming.
Like
yes. And then everyone opens the road for you. Oh. You know, the aircraft is just landed, and they still do that in I'm gonna mention in Netcare Mel Park, because we were partnered with them. They would go with us, and then they would obviously harvest their heart. We'll take our livers, and there will be other doctors taking organs. Yeah. Maybe we'll have this conversation another time.
Okay, definitely we should. And also the opportunities that are in nurses, which are broad.
Yeah,
it's something that
I don't think people know that nurses can work on oil rigs.
Yeah.
Oh.
Yes. You can do your occupational health specialty, and you can be employed by international companies working on oil rigs.
Wow.
You can run clinics in the most rural areas employed by these big international companies. I helped them set up an air ambulance service in Port Harcourt, Nigeria.
That's it.
Yeah. Nurses there from all over the world working and running these places. I really don't think people understand what nurses can actually do.
And before we even move to the next question for her, I just want to say shout out to Professor Buotha. He is now in America. He relocated. He's in the Salt Lake in America. He exposed me. He made me. He allowed me to make mistakes. That guy, it's shout out, Prof. If you can see this.
Shout out to Prof.
Yeah, he's doing very well, because apparently he's managing one of the biggest transplant hospital.
Amazing, isn't it?
Wow.
Yes. Yeah, okay.
Yeah.
I think we should allow her to continue with.
Yes,
when you were traveling and then you got to be your...
Yeah, but then when I came to South Africa, to Johannesburg, I then worked in emergency departments, ran an emergency unit, and then I started flying. And I flew for quite a few years. And then at one stage, flying is physically very exhausting. You carry lots of bags and everything. And then I decided to look at opportunities of opening my own practice.
Yeah.
And I decided to become a private nurse practitioner.
Okay.
So in the interim between all of that, when I was flying, I did my master's degree in education. So I'm very passionate about educating nurses. Opened my own training center. I had it at Wits Medical School, where I trained all the ACLS pals and all that kind of stuff.
What? Nice.
Yeah. And then I opened my own practice, and that is in itself evolved.
Yeah.
So, I opened it with the idea of doing out-hospital infusions.
What do you mean out-hospital infusion? Were you going to people's houses?
No, they were going to come to me.
Okay.
Yeah.
Oh,
so I did start.
Okay.
Yeah, I did start going to people's homes as well. But then certain of the infusions I felt were too risky to do at somebody's home.
Yeah.
And that's just because of my background in trauma and emergency nursing, and because I'm so pedantic about safety and that kind of stuff. I just felt
I can see that. I can actually see that.
vulnerable in somebody's home if something went wrong.
Okay.
Yeah. So that's why I have my little facility.
Let me get out of the dark here.
Yeah.
Can you guys please explain infusion therapy?
Okay.
So it's intravenous medication in a drip.
Oh.
So people know it as a drip.
Are you now back?
Yes.
Are you back?
Yeah, I'm back.
You back.
So drips.
I'm in the
So the lay people will know it as a drip.
Yeah.
So you're lying in hospital, you're getting antibiotics.
Sorry.
You're getting antibiotics intravenously, because remember, intravenously is directly absorbed.
Okay.
If you're taking any medication orally, it's got to be absorbed via the gut barrier. Mm-hmm. So it's not all 100% absorbed. Sometimes, depending what's happening in your gut,
Makes
it
sense.
takes longer to act. So if they need to give you an antibiotic quicker because you've got a bad infection, they'll give it to you intravenously.
Okay.
Then some people would be in hospital to get intravenous antibiotics, and they might have a chronic condition. And then the doctor will say, okay, you're only getting an infusion once a day for this antibiotic. Why are we keeping you in hospital?
In the hospital, yeah.
So let's send you home, and you can do the next 2 weeks of those antibiotics at a practice like mine or at home.
Mm-hmm.
Yes. Yeah.
Makes sense.
And that's how it started.
So that's basically giving medication through the drip.
Definitely.
Yes, that's exactly what it is.
Simple as it is.
And there's a very big range of different medications we do through the drip. Yeah.
All right. And then you've opened your private practice. Was it then, it started like infusion focused, or were you doing other things?
So it was started as infusion focused, but then I started getting a lot of inquiries, stoma care and wound care, as you would know.
Okay, yes.
So I did the postgraduate qualification in both of them through the University of the Free State.
Okay.
Did an excessive amount of wound care at one stage. And then the stoma therapy grew as well. But my passion still lay with infusions, because that's what I wanted to do. I think the infusion side of things just took longer to get off the ground.
Yeah.
So I did a presentation at, I'm not sure if we're allowed to say, Discovery Health.
Yes. No, we are, definitely. Yeah.
To try and motivate for shorter hospital stay. And you might want to take this out of the...
Okay.
But basically, I had this idea that people could stay in hospital for shorter periods.
Yeah. Why do you want us to take it out of the clip?
Because it's not always going to happen, because being in hospital produces money.
Okay.
All right. So if you can understand, a patient is in hospital for once a day antibiotics, the hospital makes money, the doctors make money. So it takes an exceptional person to say to the patient, do you want to rather go home?
Yeah.
But living in a time where hospitals are like, packed.
Yeah. I want you to not feel, to isolate that, because that is where we come as patient advocates.
Yes, no, absolutely. So I'll end up getting a lot of patients. For instance, they will say to the doctor, why am I still here? And then they will come to me.
The medical aid have a system where there are case managers are
yes, I know that,
through the hospital and discharging the patient.
Okay.
And they will say, why is this patient still in the hospital.
But remember, the doctor can still motivate for the patient to be there. If the doctor motivates well enough, the patient will be there.
Yes.
So it really depends, I think, largely on the relationship between the patient and the doctor as to whether they feel empowered enough to say to the doctor, please, can I rather go home?
Yeah.
Because patients do better at home or coming to like a
place of healing is at home.
Yeah. Or
and
coming to me once.
I mean, if you want to be in a comfortable in your home and in the presence of your family.
Not me. I want to be there.
Yes.
So there is a big drive.
We're not taking the patient out of the hospital. I just want people to understand this.
Okay.
This also works very good back to the hospital. If the hospital are packed, and we know we've got hospitals that are full. It's just on the full capacity, and the patients are waiting outside. But the patient has the procedure is done. Antibiotic first and second day antibiotic has done. So that patient can go home.
Yeah, I think it really depends on the case.
Doctor can,
but
on
there
the case.
There is a big drive now for what they call hospital at home.
Yes.
So I'm not quite the hospital at home because I don't go to people's homes anymore. People come to me
anymore.
No,
it's hospital at
because
Dale
I
place.
just really I've got 3 private cubicles. We really go out of the ways to make our patients comfortable, and they're actually okay with coming to me once a day. So if a patient presents to an emergency department with a very bad spider bite, they have it debrided, they'll say to the doctor, I do not want to lie in hospital for 2 weeks for an antibiotic or 10 days or whatever. Then they can come to me because I'm a wound care specialist. I can look at the wound, I can dress the wound, but I can also do the antibiotic.
Okay.
Yeah.
All right.
But then it landed up antibiotics is the least of what we do, actually.
Is it?
Yeah, by far.
Because my mind is sitting on the only antibiotic. And I believe, okay, maybe intestinal failure because I was involved with the colorectal
unit at Donald.
Yes, and then we were doing intestinal failure where we...
Then that's rehydration and that's TPN, that kind of stuff. Yes. But antibiotics is by far the least of what I do. It may become a big need for at home. I think and Discovery Health has their own nurses that go to people's homes to try and do it. But ultimately, it is the doctor that discharges the patient. So it's the relationship with the doctor. Where I also pick up a lot of patients is people who do not have a medical aid, but they don't want to go to a government hospital. They go to a private emergency department.
Yes.
And the lady has a very bad bladder infection, for instance.
Yeah.
And then they have to put down a 60,000 Rand deposit to get admitted to hospital. Then the doctors will phone me and say, this patient doesn't want to go to government. They don't have 60,000 Rand to pay for admission. Could you help?
Yes.
And that's where I end up helping a lot. So it's somewhere in between there.
So if the patient...
And I think that is going to become bigger and bigger.
Yes, it is. Actually, it is because I also get a lot of calls. I get a lot of motivational letters from the doctors to actually facilitate those programs. And sometimes I'll be just looking for someone to do it, but I want it to be done best. You know, I mean, now obviously I'll refer the patients to you.
Yeah.
So
how do you navigate that situation though?
I think it always brings home the fact that our medical services in South Africa are very unequal. Whether we want to admit it or not, they are unequal.
True.
So I had a patient the other day. So one of my existing clients, she's on a medical aid. She has money. And she knew somebody that had been stabbed in his hand. This young gentleman came to see me and she said, please, we're really worried about him. He's been stabbed in his hand.
Okay.
So she came to see me and it landed up, it was 3 weeks post being stabbed in his hand.
Yeah.
So he had contractures of his fingers already, had a lot of problems. The wound was septic, a lot of problems. And they brought him to me and they said, well, we don't know what to do. I said, unfortunately, you're going to have to go back to the government facility. He cannot afford a plastic surgeon or a specialist hand surgeon. And one of the nurses stood there with fiberglass and she said, but Gail, this poor guy. I said, but this is the reality of healthcare in South Africa.
Yeah.
This man is going to have to go. He's a young man. He needs his hands. He's a welder. He was a welder. He needs his hands. So that lady had paid for him to come see me to see if I could help him. But the reality, it was way down the line.
Yeah,
I could
have to
clean
refer.
the wound. I could told him what exercises to do.
But maybe there's some surgical intervention.
You definitely needed surgical intervention. But unfortunately, he has to go back to a government
And
facility.
when he goes there, truly speaking, he's going
to wait.
What are you doing? Like what? Maybe if not all the infusion therapies that you are giving, but just mention the common ones that you are doing.
So when I spoke to you off air, we were talking about iron infusions.
Yes.
So
yes.
iron infusions is becoming more and more prevalent.
Okay.
Because doctors are starting to understand now what iron deficiency is.
Okay.
At medical school, and I think this is the same with nurses, you get taught that when your hemoglobin drops, your HB,
Yes.
you become anemic.
Yes.
What is the cause of this anemia is often iron deficiency.
Okay.
So what? Because we need iron to make hemoglobin.
Yes.
That's the molecule in the red blood cell that carries our oxygen.
Yes.
We need iron to make that
Yes,
molecule.
Yes.
Or that protein. So if you become iron deficient, that protein starts dropping, so your HB starts dropping.
Okay.
So what most traditionally would happen is doctors would test the HB. If the HB is normal, they don't go further.
Okay.
But what we have learned now is that a low HB, and this is a bit technical, is a late sign of iron deficiency. So that's what we call anemic iron deficiency.
Okay.
But you can get non-anemic iron deficiency, which is very prevalent.
Okay.
Up to 40% of women can have non-anemic iron deficiency. That means your iron levels are dropping, but your HB staying normal.
Stays normal. Okay.
No, but that's the beginning of it.
Okay.
It will get to a stage where there's not enough iron to make that HB, but that's a late sign.
Okay.
But having iron deficiency without your anemia, what we call non-anemic iron deficiency, has its problems in itself.
Okay.
And people are becoming more and more aware of this. So now doctors, when patients go to them and they say, I'm fatigued beyond, I do not know what to do with myself. I want to fall asleep in the afternoon. I'm struggling to concentrate at work. They're starting to test iron profile.
All right.
Even psychiatrists are starting to check the iron profile because iron deficiency can lead to anxiety and depression, which a lot of people don't know.
Stroke.
Huh?
And stroke.
No, different thing.
Is it?
No.
Okay.
No, different thing.
Let's leave it different. Yeah.
No. So iron deficiency, we need iron not just to make HB in our bodies, but we need it in the production of ATP, which is our energy center of our cells.
Yes.
We need that. We need it to produce myoglobin, which is our energy molecules in our muscles.
Okay.
It is an essential. We need it for the development of neurotransmitters in our brain.
Okay.
So we need it for a whole lot of things. And so the prevalent sign that people will go to the doctor is, I'm fatigued.
Okay.
And now doctors are starting to test not just the HB, they're checking the iron
program.
Well, they call it iron profile or iron studies.
All right. Okay.
And they starting to
iron studies.
Yes, they're starting to look for iron deficiency. Other complaints that people have with iron deficiency is hair loss. Very common. Hair loss, cold hands.
What do you mean hair loss?
Hair loss.
I mean, I don't have a working
Hairline.
Yes, so women will go to the doctor and say,
Are you worried? Are you worried?
No, but women will go to doctors and say, my hair is falling out.
Will it be literally like having your hair in your hands?
Yeah.
Okay. Yeah. All right.
You probably find yours is normally like this. I don't know.
Yeah, no.
You won't know.
But I don't think it's a bad thing for me to check my own status.
No, exactly.
Yeah.
Yeah, exactly.
Yeah, I'll do it.
Yeah.
Because you talked about fatigue as well.
The other thing is very common with iron deficiency is restless legs. Have you heard of people complaining of restless legs at night?
What do you mean restless legs? Are they
legs
just being busy?
And they can't sleep because their legs are restless.
Jeez.
That's iron deficiency. And one of the big things, and people actually make money out of this, is a thing called pica. When you're pregnant and you crave odd foods.
No.
Yeah.
I don't know if you want to talk about what I'm thinking.
Iron deficiency can cause, not in everybody, but can cause a thing called pica.
Okay.
And women, pica,
Okay.
P-I-C-A.
Okay.
And the two things that women often crave when they have pica with iron deficiency is ice and clay.
Thank you. I wanted to say clay. When she said craving, clay, what sort of taking?
Yeah, the stones or
stones.
Those mud.
Yes.
Mud stones. Yes.
So you go to any university or any tertiary institution, there are people selling young women clay.
No,
Because they
you
are
say we go to university. Oh, you go to anywhere.
Anywhere they sell clay.
Yeah.
Jeez.
Outside the clinics, they sell clay to young women
And I bet
because
it
they've
does
got
have some
they're
bad side
craving the
effects.
clay. And that's iron deficiency.
And you can imagine what does that do in your digestive
Does have side
program.
effects.
Yeah.
I'm telling you,
Yeah.
because I mean that is not in the nutritional space. I don't understand.
What is it that it fills them with when they eat it?
Though it's actually got something to do with the crunching. They think the iron causes some disturbance, and I can't explain it all. And it's the same with ice. Ice has no nutritional value. It's about the crunching of the ice. It's very
It's
interesting.
more like psychological mindset.
It's very, very interesting. So that is one of the signs of iron deficiency.
Is it?
And iron deficiency is actually very prevalent in young women
Okay.
because we have, from the age of 12 or 13, start our monthly menses.
Yes.
And you lose blood and iron every
yes.
month. And so it happens over time that every month you may be losing more iron than you are consuming. So progressively you become iron deficient. So it can happen over a while. So it's not like overnight I bleed and I bleed it all out.
Yeah.
It happens progressively.
Yeah.
And that's why they also often don't pick it up, because they will progressively become more tired, progressively lose more hair, become restless, cold legs and feet and hands. And then one day they just go to the clinic or the doctor and they say, I'm so tired, I don't know what to do.
What could be the most complication if you are not taking action with regard to your iron?
Well,
What could be the bad?
Well, besides being excessively fatigued, if you think about it, if you're studying at university and you need to be studying and you're excessively fatigued, it's a very difficult thing to manage that. Once you become anemic as well, and we do see that a lot, that women are presenting to the doctors and they have an HB of 10, 9, 7, which is extremely low. And HB is normally like 12 to 16, very broadly speaking.
It should be from over 12 years.
Yeah. And they're presenting when they're anemic already. And then that has effects on your heart. That becomes a critical thing then, because now your heart is having to work so much harder to circulate the bit of HB that can carry the oxygen. So, yeah.
You know, I saw a clip on TikTok. I think I even recorded that because I knew you were coming and I wanted to discuss that with you. I saw a patient that the son was saying there on the clip that she's got stroke due to from an iron deficiency, lack of iron.
It's very interesting. I would have to look up.
Yeah, I mean, I recorded. I actually downloaded that clip, and then I said, okay, I'm gonna discuss this with Sister Gail, because that
you see, was it a young person?
It was no, the patient was not young. The patient is maybe your age.
That's young.
I don't even know how old you are.
That's young. That's very young.
By the way,
camera.
What would be the perfect substitute for a pregnant woman who wants to chew instead of ice or...
So when a pregnant woman gets pica, that's different as well. That might be hormonal. It's not necessarily iron.
Okay.
Pica is also happens in pregnancy, so it might not just be iron. But the studies are showing us now that before women are wanting to fall pregnant, they should check their iron levels because you need to optimize your iron because your baby is going to need the iron for neurological development. And what they are picking up now, iron deficiency in pregnancy results in children, not always, result in children having cognitive deficits, including attention deficit disorder, not functioning very well at school, not able to get a tertiary qualification. They've tracked it all the way into their 20s and 30s, yes.
Wow.
So we do a lot of iron infusions for pregnant women. When they're pregnant to it. But the drive now is to rather know your iron levels before you're pregnant.
Yes.
Especially as a young woman, you think maybe it's time to fall pregnant. Let me check my iron levels. And again, I know it's difficult in government facilities because maybe money is an issue. But you can check a ferritin, what they call a ferritin, which is your iron stores.
Okay.
You can check a ferritin. And if it's below a certain level, you are iron deficient.
Where do they check that?
It's a blood test.
Okay.
It's a blood test.
Oh, okay. So it will be a test that you
It's a
need to
blood
go
test.
to any lab and do it.
Yeah.
Okay.
Blood
All
test.
right.
And then you start oral iron supplements.
Okay. All right.
So-
Even before you fall pregnant.
Yeah, absolutely. And a lot of the gynaes now are putting their patients onto oral iron from the beginning of their pregnancy already.
Okay. Yeah.
And they're monitoring their iron along the way. And then when it gets to a certain time that we can see maybe the oral iron is not sufficient, we need to give them intravenous iron because it's then absorbed quicker and it acts quicker. Okay, because the oral iron is not getting absorbed as much as it should.
Wonderful. By the way, before we continue, guys, if you're a nurse and you're watching this, you are definitely enjoying this.
Yeah.
If you're not a nurse,
Like
and you're
Kay,
watching
he doesn't know what we're talking about.
Konabo intro with what? GB, HB.
Yeah. HB.
You know?
Yes.
That's high blood, right?
No, that's
No.
hemoglobin.
See what I'm talking about?
Blood in your body.
Okay. If you're not a nurse and you're watching this, you're probably just thinking, okay, probably need a dictionary. But if you are a nurse, you are getting all the great nuggets that you need.
Yeah.
Don't forget, get a notepad, write down all this information, and don't forget to subscribe, like, and share. Because this is something you're going to have to keep up with. It's not just a one watch.
Yeah.
You're going to have to watch this, come back, rewind, watch it again. No, you know what I mean? There are too many nice nuggets.
I think
that-
not
yeah.
only nurses, because now she's just stated a lot of indications that
Yes.
iron deficiency comes with.
You
You
understand?
know, the pregnant woman at home, guys. And then would you advise them not to buy clay?
Definitely not.
Definitely.
No, don't.
No.
No.
You know?
Yeah.
But it's such an overwhelming craving that it's difficult for them. But that is a sign. Yeah.
What would be the alternative, though, if they don't take
They must
clay?
take oral iron. They must always start
No,
with oral
it's
iron.
an indication of iron
Deficiency.
So they need to sort their iron studies or iron level in the body sorted.
Yeah.
Yes.
And it's really,
Right?
really important. And if you ever wanted to, Maureen, I'd be happy to do a detailed talk on iron and iron deficiency because
That is
I've
very
learned it
important
so well.
because-
Yeah.
Yeah, that is another thing, Sister Gail, because I've been encouraging people who does the cosmetic IV because everyone is running to that department. Guys, start focusing on adding medical IV related therapies.
And know
Which
your product.
IV? Yes, and know your product. Yes.
So I've been very fortunate with iron. I've done some extra courses in it. I've developed some really good relationships with professors. So if I ever have a query, I can phone them.
Yeah.
I've also developed such good relationships with my doctors that a lot of the doctors will send me the blood results
Wow.
and ask me, what do you think? How much do you think?
Wow, nice.
And that's
Well
how we
done.
work.
Yeah,
So it's really, really
definitely.
great.
So apart from iron is going to be a main topic. I love this. I love iron. I think
There's a big need for it.
yeah, it's a big need, and it's more like an abundant discipline at the moment
Is it?
in the PNP, in the private practices.
Okay.
A lot of people are not educated about it. That's why we have Sister Gail here today.
Definitely.
And then a lot of people are not doing it. And medical aid pays, guys. Medical aid pays.
It
for
depends. I have to tell
Oh, okay.
interject
All right.
there.
Okay.
Okay, thank you.
So oral iron is always the first thing you've got to go for.
Okay, which you can buy at any pharmacy and
Yes, most. Some of the better oral irons are scripted, but yes, oral iron is the better way to go first. But there are certain times where oral iron will not get absorbed. So somebody's had a gastric bypass surgery, they cannot absorb oral iron, they can't absorb B12. So they have to have their iron profiles done at least every 6 months and then probably have an infusion, a drip, because that's market. Then you have people with autoimmune diseases like Crohn's, ulcerative colitis. They also struggle to absorb nutrients, and iron is a nutrient. So they may also then land up getting intravenous infusions.
Okay,
rather.
all right, okay.
And if you've got any chronic inflammatory condition, that comes along with a hormone called hepcidin, and hepcidin blocks the absorption of iron orally. And even with athletes, we're seeing iron deficiency in athletes.
Okay.
Yes. It's a very interesting, and it's all got to do with the hormone hepcidin. Hepcidin, if you run in a long marathon, you secrete a lot of hepcidin. It prevents the absorption of iron.
You see, this
So
is
it's a very
department on its
interesting
own.
field.
Exactly.
Yes.
I mean, that's why it's a very big department.
So I think if you ever wanted to do a talk on it, we set up a board, we explain it all.
Yeah. No, I would love
Yes.
that. I would really, NBS would
So then you
That'd
can
be
sponsor
lovely.
that because
That'd
I
be
think
lovely.
educate
there's
the
a
nurses about.
there's a need for education. There's a need for education.
Master
People,
classes,
yes, master classes,
specifically.
and you host master classes, right? You have classes for these infusion therapies that you do.
So I've designed a course that I've got, and I've done a few of them, where I teach nurses about the physical aspects of infusions. In other words, the different kinds of administration sets, drip sets, cannulas, how to manage anaphylaxis or bad reactions to infusions. I have an IV mannequin arm, then they can actually practice putting up drips and that kind of stuff. So I do that.
Mm-hmm.
I think there's a very big need for it. And I have to say that if you're ever going to do medical infusions intravenously, you've got to, and that is part of our scope of practice, whatever drug you're going to give, whether you're giving it orally or intravenously, you've got to know the drugs.
Yes.
You've got to know the mechanism of action of that drug.
Yes.
You've got to know the potential side effects, and then you've got to be able to manage any emergency relating to that drug.
Yes.
You really have got to be able to do that.
And also that helps you to be ready for in case there's any kind of
Yes, and
complications.
we've had.
We've
had.
Okay.
So you said medical aids don't pay?
No,
All
not
of them?
don't. She said
There's
not.
criteria, and
Yes.
one of the criteria is you have to have done oral iron, unless you have one of these conditions I've met.
You'll have
You
to
have to have
start
done
with the
3
oral
months of oral iron.
Oh, okay.
Unless you have an existing condition that prevents absorption of the iron, or unless you are extremely anemic and it's now threatening your life, then they will pay. They will also only pay for high doses of iron. They don't. So there's different
There's
iron.
a lot of
There's
training
different iron compounds on the market. Yeah. So I've compiled a list for my doctors where I've actually compiled, and I said, this is what the medical aids will pay for. This is what is the criteria, and I send that to the doctors. So they know exactly. Don't just refer everybody. Make sure they've met the criteria before you want to go through the extensive process of motivating. But yes, the medical aids are getting on board. There's 1 or 2 that are still dragging their feet on this area, especially in pregnant women, because they're realizing now the consequence to the fetus of iron deficiency in the mother. It's long-term consequences, and that has legal implications to them.
Yes.
So, yeah.
Wow, this is
By
very
the way, before you continue, talking
Yeah.
about paying, if you're a nurse and you've got a private clinic or anything, and the medical aid won't pay for any amount that patient wants to pay, you can actually be part of this competition that we have, and you actually don't have to pay for a ticket.
Okay.
All you have.
Oh, yes. I thought you wanted to say we can pay for you.
No, if the medical aid doesn't want to pay, you probably don't have money to buy a ticket. How much is the ticket again?
750
750
for non-members.
Yes. And now we have a competition for people who maybe cannot buy the ticket.
Yes, we've got 5 tickets up for grabs. So they just have to go to our YouTube channel, and then on any video they just say Second Global Nurse Rise Summit, and then you just type that, and then we know you want a ticket.
Hashtag
What is hashtag? I'm a nurse. What are you talking about?
Hashtag. So you can put it. It's actually perfect. Hashtag Second Global Nurses Summit.
They must start with hashtag.
Yeah.
Okay.
Hashtag Second Global Nurses Summit, and then they must share the event, and just make sure you share with everybody else.
Yes, and they must do it countless times. They must not say, okay, I've done it once.
Yeah.
It's a competition.
Exactly.
You want to win it,
Your
so
name
do
must
it
be
and
up
do.
first.
Yes, and then we will announce on them. I think we'll talk about the days to announce that, because this is a new thing that we are introducing today.
Definitely.
Yeah, but we do believe that people want to come. They want this information, and unfortunately, they don't have money to buy a ticket because obviously they are not working on all of that.
Yeah.
So we've got 5 tickets to give for free. Okay, up for grabs. You have to enter into the competition.
Sister Girl will be speaking also.
Sister Gail is coming, and you know what? Now after this, I'm going to structure her topic on iron deficiency.
Yeah.
Nice.
We are going to actually talk after this, because we need awareness. We need to reach out even in the rural areas.
Absolutely.
That's where we non-stop
absolutely.
go in there.
Yeah.
And obviously diet, there's certain things you can eat to improve your iron. But we know that as a young girl starts menstruating, that becomes more and more difficult. So the option of an iron supplement, and the government clinics provide iron supplements. So there is an option
they can go
to
there
that.
and get that.
There is an option, but people don't ever test the iron or the ferritin.
Do you have the testing kit or the testing system?
So there is a rapid ferritin testing
I
kit.
wanted to ask about the rapid.
It's not that reliable, I don't think, but it is there. And I'm not sure what the government facilities offer when it comes to drawing blood, but I'm sure there is ways to do it. If you're drawing blood to test an HB, a hemoglobin, you can do a ferritin as well.
Definitely.
Yeah. Because I think that is another space where we can maybe do a research in terms of getting the companies who can actually consider giving providing with the accurate machines or systems that we can quickly check like here. We are 1, 2, 3, 4, 5, 6, 7. Then we just check our
ferritin.
Yeah,
and then like we do with HIV. Now it's very just
there are rapid tests on the market.
Yeah.
And what type of infusions do you offer at your center? And also you can just take us through the process of actually preparing and the aftercare.
Okay, so the easy way to explain it to you is that we do medical infusions as prescribed by the doctors.
Yes.
That's very important. So we are not stepping out of our scope of practice. So as much as I can identify an iron deficiency, my patient still has to have a prescription.
Yes.
So sometimes a patient will phone me and says, the doctor said I must contact you.
Yes.
Then I say, okay, send me your blood results. I send the blood results. And then I'll say, tell your doctor to prescribe.
Okay. All right.
So I will never do an iron infusion, for example, without a prescription.
Yes.
Never.
Yes.
Ever.
Yes.
Okay.
Yes.
So that's my scope of practice as a registered nurse. These medications must be given on prescription. So there is a doctor involved.
Okay. All right.
So if
this is with all your IV,
all the medical infusions.
Yes.
The only thing we don't do is chemotherapy.
Okay.
Because I do believe chemotherapy is a more specialized area. There are oncologists that have their own chemotherapy units.
Yeah.
And that's not one of my areas of knowledge.
Yeah.
So we do not do chemotherapy.
Okay.
We do the odd chemotherapy drug, but it's often given for something else.
Okay.
Not cancer.
Okay.
That makes sense.
Okay.
Yeah. But again, prescribed.
Yeah.
So in the case of like iron, you would have had to have done your blood tests. So we can see your blood tests. The doctor would have prescribed the iron.
All right.
If it is a case where we believe the medical aid can fund this, because if you're looking at high dose irons, you're looking at starting at about 5,300 Rand, going up to 8,000, 9,000, 10,000 Rand just for the infusion. We do biological agents that patients do for autoimmune diseases.
Okay.
One of the drugs for multiple sclerosis per vial is 30,000 Rand.
Oh.
Jeez.
So we have gold in liquid form at our practice.
I'm telling you.
So that should give you. So if it's a biological agent, if it's iron, they would have seen their specialist doctor.
Yeah.
It would have been decided this is the route they've got to go.
Yes.
This prescription gets sent to me, and then we start the process of motivating for it.
Okay.
And when we're motivating for funding from their in-hospital fund.
Okay.
Not from their savings.
So,
as you can imagine, a drug like that will deplete your savings.
Yes.
Yeah.
So, okay, very interesting. In-hospital savings, right?
No, in-hospital fund.
Funds.
So we are doing the infusions in lieu of hospitalization. So we're saying to the medical aid, you either pay for the patient to go to hospital and get this drug, or you pay for them to come to me and get this drug.
And which
it's
is
much
cheaper
to come to me.
Yes, yes.
That's what we do.
Okay, so even if the patient is not in the hospital, they still approve
from their hospital benefit.
Oh, okay.
Yes.
All right, nice.
That's the motivation that it's done, is for to be funded from their hospital benefit.
Okay, all right.
And some of the medical aids may not fund it. They'll say, yes, we're going to pay for it, but it must come from your savings.
Yeah.
But but there is a lot of these things now that the medical aids are on board with, and they're paying from their hospital benefit. That is the whole idea of a motivation.
Okay, all right.
Yeah. A lot of the companies have what they call patient assist departments.
Okay.
That also assist with getting motivation. So I will send it to that department.
Oh, you're working with them?
Yes.
Okay. They're doing your billing and all of that?
No. I do my billing myself. But to get the authorization.
To get the and to talk to the medical aid, which is another hassle, right?
So
that's very stressful, yeah.
So once we've got the authorization, then I've got 2 big wholesale pharmacies that will then deliver the drug directly to the practice. And we make the appointment for the patient and we administer the drug.
Normally, how often do the patient receive the drug? Is it going to be daily or?
It depends on what you're getting.
Yes.
So a high dose iron infusion may be 1 infusion or 2 infusions. A biological agent for autoimmune diseases would be every 4 weeks, every 6 weeks, every 7 weeks, every 8 weeks. It really depends on the condition of the patient. And like biological infusions are authorized for 6 months in advance. So then we set out the dates for 6 months in advance.
Talking about the condition, how do you actually, make the patient comfortable?
So let's go back to iron. I think that's an easier one because it's such a broad thing. So once the authorization is given, I do send the patient what we call a iron information leaflet that we've compiled that gets sent to them before they arrive at our practice. That explains to them in detail what iron deficiency is, what they can expect during the infusion, how we're going to put up the drip, what possible side effects they could experience. So it's what to do before the infusion, like you shouldn't take your oral iron on the day of an iron infusion. What we're going to do during the infusion, how we're going to monitor them. And then it also includes what to do after the infusion, what they must do as a patient after. So they have that before they even get to the practice.
Well, you give them the education.
Yes, they're very well informed before. And that is part of informed consent.
Okay.
And on there, it talks about you could have an allergic reaction.
Yes.
It's a small chart, but you could.
Yes.
And this is what it would look like. And this is what we're going to do. And then when they arrive at the practice, we also then, specifically like for iron, we have a pre-infusion iron questionnaire, which again is the second level of confirming what is a high-risk patient and what's not a high-risk patient.
All right.
So if you have a high-risk patient, so for instance, somebody who has asthma has a higher risk of having an allergic reaction to iron.
Yes, okay.
Then the decision is, do we pre-medicate the patient? In other words, do we give them an antihistamine? Do we give them cortisone? That kind of stuff.
Yes.
So most patients we do not pre-medicate, but we have to identify the high-risk patient.
Okay.
There are conditions like first trimester pregnancy is contraindicated to get intravenous iron.
Okay.
So, and people don't always realize that. They have to wait until they're after their 12 weeks.
Oh.
There's a condition called mastocytosis when your mast cells are secreting all the time and you are hyperallergenic to many drugs. Absolute contraindication to get iron.
Okay. All right.
So that pre-infusion
assessment or checklist
will flag a high-risk patient for us. And there have been a few patients where we've actually said, you are too high risk, we can't do this.
That's it?
Yes.
And then you send them to the hospital?
No, they mustn't get the iron infusion at all.
At all? Wow.
So and it's just sometimes it slips through the system. And a typical one was a patient with mastocytosis. She was pregnant, far pregnant. She had a PhD. She was a doctor in pharmacology. Her husband was a doctor in pharmacology. And nobody picked up the mastocytosis. And when she did the checklist, she said, but I've got this. I'm like, we can't do your iron infusion. We absolutely can't do it.
Wow.
And then I phoned her husband and he said, no, she must get it. He knows what he's talking about and everything. So then we got hold of the doctors and I got hold of one of the professors I know and they said, you cannot do this iron infusion.
Yeah.
So she couldn't. We would have
had very important.
We would have had 2 lives in real trouble there if we had done it. So that's how we try and flag a high-risk patient. So I once had a patient that came in, when I say morbidly obese for an iron infusion. She couldn't even stand. She had to have a helper to get her to walk. A lovely lady. But when I put her in the chair, I'm like, and I did her vital signs and everything. This patient is a high-risk patient to do iron infusion simply because if she had a full-on allergic reaction, it's going to be a very difficult case to manage. So we said, I phoned the doctor and I said, we cannot do this infusion here.
What could be the most complication?
Anaphylaxis.
What?
Anaphylaxis to iron.
And you need ICU for that? or
No,
adversion
we've had anaphylaxis. You can manage anaphylaxis, but you've got to know what you're looking at. You've got to be able to manage it quickly. And if you pick up the early signs of an allergic reaction, you manage it quickly, you won't progress to anaphylaxis.
What do you do? Do you stop?
Yeah, we've got a whole process that we do. Yeah. So
because that is the a lot of concerns that comes to my GMs. People who say, but it comes with a lot of complications. It's very risky to do it in the rooms.
No, I think you've just got to be able to assess your patient correctly.
Yes.
See what you consider a high risk patient. And yes, and sometimes as a nurse, I really believe there are times when you're going to say, this is too high risk for me.
Okay.
I do not want to do this.
Yeah.
Because I'm now also considering my safety, not just the patient's safety. Yeah. This is too high risk for me.
And also to have all of those equipment that will actually complete your emergency.
Yes. We are. And that's why I developed the course to teach people how to manage anaphylaxis.
Okay.
How to identify a normal allergic reaction versus an anaphylactic reaction. The one is not life-threatening. The one is life-threatening, and you've got minutes before the
Had you ever had a situation where you've got a condition and you really, it's out of hand from iron?
Yes, I had a full anaphylaxis in a 38-week pregnant lady. It was very stressful. But we managed it really, really well. Because we practice it at our practice, because I've got a simulation mannequin.
You are told.
Yes. So we practice over and over. We really do.
Okay. Nice. So talking about all this that you do, right? I'm thinking about how you know so much, and obviously you may have been through so much in starting your facility. What are some of the challenges that you have faced, when you were starting up?
Not necessarily from a nursing point of view. I think my biggest challenges were, and I think that's why NBS has been established, is how to bill a medical aid, ICD-10 coding, financial management. I had to learn a lot.
Yeah.
Tax management, getting a good tax person on board.
Yeah.
Jeez.
That's, as a nurse, you don't learn that anywhere. Nobody teaches you that.
We don't have a module that teaches us on financial management skills, business management skills, marketing skills, which is very important. In our department, as a nurse or in the health sector, it's difficult to market.
And you know what was interesting for me? One of the most difficult things, Ms. Roberg, I'd worked in government for many years. I'd worked in then very fancy private institutions. Never have I was always employed by somebody. Then when I went into private practice, I had to ask for the money.
Oh.
And that is, for me personally, was a big challenge. And I can see it, and I think this is where sometimes private nurse practitioners are detrimental to each other. So because nurses are caring, you'll often get a case where they'll say, oh, no, shame, let me just help him and do it for free. That becomes detrimental to me because I cannot compete with a free service.
Yeah.
Definitely.
So it's quite a mindset for me personally to say, I deserve to be paid by you for what I'm going to do for you now.
That's true. No,
it was. Because I was always employed. Somebody else was paying my salary.
Definitely. Yeah. Everything was covered for you.
Yes. So, but once you realize, and then my mantra became, I can offer a discount, and I do. I often help old people. That's my thing. I often give my old people a discount on their infusions and that kind of stuff, unless it's pre-authorized. But I also have said it is not my responsibility to pay for your health care.
Definitely. I mean, you have to.
So you have to find that boundary of, I'm going to help you, I'm going to give you the best care possible, but I still have to pay my water and lights. I still have to pay my staff.
The stuff
I
that
still
I'm
have to put
using
my
on you.
petrol in my car.
Yes.
Now, talking about all that that you had to learn, how, I want you to also tell the nurse that could be watching this, right, that wants to start their own practice. Like, NBS, I mean, we cover everything for you. What do we cover, sister?
Okay.
Yes.
Okay, we as NBS, our main vision is to uplift and empower nurses to be independent.
Yes.
By so doing, we have realize the gaps that Sister Gail is actually mentioning here. And it looks like, Kay, each and every guest that we have, they go through the same challenge. Yes. So you want to open your practice, your private practice. Yes. You don't know how to start.
Yes.
You don't have capacity in terms of finance. You don't know how to open your business. You don't know which channels to take. You are busy asking yourself if will this work but then the biggest question is that, the answer for you will be, what if it works?
Exactly.
Because it can work if you come to NBS.
Exactly.
NBS Business Solutions. What do? We help you to open your own company. We will help you. We are very well structured. We've got people that are able to help you to open your own registered company. And then we've got HR. She's talking about HR department.
Yes.
Guys, it's very important. To work without HR management is a problem. You need to come to us so that we can help you, because we have that department sorted or organized,
Definitely.
And then you will need to have someone managing your books, How do you just work without knowing if you are making income or not? You are making profit or not?
You know what I mean?
Yes. And then what seems to be the biggest challenge is billing and coding. Nurses, everyone who is in the healthcare sector, please do not lose money. Come to NBS. We've got billing and coding programs that will help you on which codes to use. ICD-10 code. If you are hearing and listening to ICD-10 code for the first time, then please come to us. Let us help you. And then we've got procedure codes. We've got our way of communicating with medical aids.
Sister Gail,
Yeah.
with all the struggles, trials and tribulations you have started, you had to go through when you were starting up, right?
Yeah.
And also, you said you had to look for money, right? When you went into private. Another thing is that Standard Bank has partnered with NBS for people who want to start their own businesses to say you can actually have a chance to be funded, right? What do you think to the nurse who's watching this? Like, how important is NBS to them right now, according to everything that is being offered?
Well, I think from my personal experience, if I just had somebody to guide me on the non-nursing sides of opening a practice, because I'm a nurse. I know nursing.
Yes.
I learn my drugs. I know how to manage the side effects. It's the non-nursing sides of things. And if you have somebody like NBS that would hopefully will then take the nurse by the hand and say, this is how you register a company with CIPC.
Yes.
This is your responsibilities as a director of a company, because there is responsibilities in there. This is how you make sure that you're compliant with SARS, because SARS, you have to be compliant.
It's a must.
There's no way around it. And every time I pay my VAT, I want to cry.
Yeah.
But I have to do it. You have to. There is no way around it.
Yeah.
You have to do it. And then how to bill. What should your invoice look like?
The vet story is not friendly, I'm telling you.
I know, right?
But we have to do it. The vet story, paying SARS, it's not a friendly pay.
It's not a negotiation.
I'm telling you, I've got a very good accountant. I'm telling you, she'll phone me even in the middle of the night. She'll say, don't forget, you have to pay.
Yes. There's no way around it.
I love her. And she's part of MBS. Her name is Tinyuko. Shout out to Tinyuko. Tinyuko has made exclusive medical agency to be compliant. I love her so much.
And you have a sense of relief when you saw us compliant.
I'm telling you, don't look sides. Remember when you are working and you are not sure if someone was just gonna
just knock on your door and say, "Hey."
Yeah. All right.
Yeah. So the importance of NBS in these.
Well,
times.
I think you've also got contacts with hopefully getting dispensing permits.
Yes.
That kind of stuff.
Yes.
So if you were going to have an infusion center or a private practice where you're going to administrate infusions, you have to have a Section 22A.
Yes.
Which license you to store medication on site.
Yeah.
As much as my medication is prescribed, it's delivered, we administer it, I still got to store it on site.
Yes.
And that is a Section 22A.
Yes.
Yeah, you've got to have that.
So, the good thing, Kay, is that of everything that she has mentioned, the event on the 8th of November actually entails everything. Understand? We are going to have sister. She's not a sister. She worked in the Department of Health. She helps. She's got a company that assists with permits. So
that's wonderful.
Compliant is very important in NBS. You cannot run a clinic and you are not compliant. We make sure that your documentation are in order. before you start working. You understand? That is very, very important. So
something like a consent form that your patient must sign.
Yes.
Wow.
Yes. So if you want to open a clinic and you don't know what to do and you don't know when to start, just make yourself a favor, come to the event.
Definitely.
Because in the event, you are going to feel like a CEO,
Exactly.
already before you are one. Before you become one.
Definitely.
Yeah. Also to take your mind away from your day-to-day involvement, which is patients, the situation at work. You want to interact with people, with companies. We've got stakeholders that will be there. We've got a lot of companies. We've got I'm allowing even nurses who are already in the business to showcase their products. Yes, that is what we say. That is when we say now we hold each other by hand, because there are people who approach me to say, Maureen, I don't have marketing skills and I want to market my business. I just received a call last time from a pharmacist. She is unable to get an employment, but then now she's got her own product that she's formulating, and then she is struggling to market them. You understand? And she wanted things like SAPRA license and all of that. I said, no, SAPRA representative will be at the event. I mean, come to the event. That is the reason why we are having all these networking events.
Exactly.
Yeah.
Exactly.
Okay.
Talking about that, let's go to the next one. How do you handle the marketing, the finances, and also staying focused on the patient?
I'm interested on the marketing as a nurse.
How do you handle all
Yeah, no, look, I am an old school nurse, so yes, I'm not into social media. And maybe one day I will be, but not at the moment. So I do have a website.
Okay.
And the website, there's a doctor's referral form on the website.
Okay.
So people can go on the website. The website does give some information about what we do. But I can tell you, my marketing has probably been word of mouth the best of all.
Okay.
So you get I go see a doctor, I tell them what we can do. They refer one patient. One patient, if they have a good experience, they will always go back.
Can I ask before you move? You go to the doctor. So what do? You go to the doctor's rooms?
Like a rep, and I make an appointment.
Wow.
And I go and meet the doctors.
Guys, I said to you, make relationships with the doctors.
Yeah.
The biggest client you have or you want in your business is your doctors. And as nurses now, while you are busy with your bedside nursing, those doctors that come to do rounds, talk to them. You understand? Those are your clients. Thank you for actually telling me, raising this point, because this is very important.
So if I don't actually visit them, and it's sometimes really difficult because I'm so busy to take 2 hours out of my day to go visit a doctor.
Yes.
I do a lot of telephonic consult with the doctor.
Yes.
We'll chat and I'll give advice, or they will say what they want, and if I can help, then we do it.
Yeah.
And so then I try and build a relationship. And then after an infusion, I always send the doctor feedback. To the doctor.
Very important.
Very important.
Very important. If the doctor, it's like with all services, it's not only with the IV or infusion therapy, even if it's a wound or anything, please give the doctors, your referring doctor, a feedback. And one thing I want to say, those receptionists who always gatekeep and they don't allow us to make appointment, I'm watching you.
What's the issue then?
But I find if you develop the relationship with the receptionist, it's as good.
Yeah.
Well,
I think you've just also got to develop the relationship with the receptionist, because they also will say to the doctor, there is this place that can help.
Yeah.
It is a difficult industry to get into. I have to tell you, my first month that I opened, one patient.
Jeez.
One.
You're
First
joking.
1 month.
Wow.
One patient. Yeah. For infusions.
Jeez.
One patient.
And
but I substitute.
continue.
I was absolutely. But remember, I was substituting. I was still teaching. I was still flying. So I was substituting my practice. But I had one infusion for my first month. It was difficult.
And look at you now.
Yeah. Now we average between 40 to 50 a week now.
Yeah.
Jeez, how do you even stay with the trends?
So, because of my background in education, I'm very passionate about that. So, in-house, we try to do 2 up to 4 training days per year.
Okay.
I have a mannequin that we bring out. It's a big adult mannequin. You can resuscitate him, you can shock him, you can intubate him, the whole two. His name is Norman.
So I wanted to say it's a guy.
Yeah, his name is Norman. So whenever we have
Norman.
I hope you're okay, bro.
Okay, please don't make me do this.
So whenever we have a training day planned, all the nurses ask, Norman going to be there? Because then they know we're going to be training on Norman.
Okay.
And then on those days, I tend to try and get representative or nurse trainers from the various companies. So you remember, a lot of these companies have nurse educators within the companies. You need to get them on board because they will also come and educate you about what is the latest, how we administer this drug, what are the potential side effects and that kind of stuff.
Okay.
So that's really, really, really important.
Okay.
And then we've one time I allocated drugs to each nurse and I said, go research it and come teach us about it.
Okay.
Yeah. And then you have to learn the indications, side effects, drug interactions. You need to know that kind of stuff. And then I try and stay on trend by attending a lot of online updates.
Okay.
So the University of the Free State with Professor Claire Barrett have really nice updates on iron deficiency, and anybody can log onto it. If you ever want to do Professor Vernon Lowe, he's from the Western Cape. I think he's at Stellenbosch University.
Okay.
He's got YouTube channels up. He's got so many all to do with iron deficiency and explains it really, really well.
That's one.
You know, from listening to you, I mean, you are more passionate with iron.
Iron.
No, with all of them. It's just I do a lot of iron.
Oh.
No, with all of them, you've got to know them. Your patient is going to come there and they're going to ask you questions.
Yeah.
And most of the pharmaceutical companies also publish patient information brochures.
So that
you can also give that to your patient.
Yeah. The reason why I'm mentioning this is that we are going to add this in our program for next year.
Yeah.
So as much as we host classes for all other services or training support that we have in terms of training, we add in Sister Gail's training, iron, which is the biggest one. And then hospital, post-hospital or post-discharge intravenous therapy as well.
Antibiotics.
Yeah. So we just want to unlock those doors because I am saying here again that guys, do not focus on cosmetic related in IVs only. Because there's a lot in that. I don't want to elaborate a lot because I feel like sometimes people do that just to have salary, but they don't really invest into it as a medical setup, you understand? Yeah. So let's actually value our skills. We can do it and we can do it best. We know how to put the drips. So and that will help with market because medical related IVs are actually a need.
Definitely.
You need that. You don't want, you need.
Need it.
You understand?
Yes.
It's not a want, it's a need.
So let me just give you an example. So what often happens is patients will see a GP or a doctor and they say, okay, you need an iron infusion. We go back to iron. And they'll say, okay, well, where do we go? And the doctor will say, just go to your emergency department. That often happens.
Okay.
So the patient then goes to the emergency department and sits there for 6 hours before they will get help because this is not an emergency.
Yeah.
So now you're giving them an option of it somewhere else. Do you understand what I'm saying?
Yeah.
And that is really important. So a lot of emergency departments do these infusions.
Okay.
But they don't want to do these infusions because it takes up time. They don't make the needed money maybe on it. And it's not their prime focus. Their prime focus is emergencies. So,
I'm starting to think in the rural areas, I don't think they have any idea of what we are talking about.
No.
I think the training is going to be very big, ma'am. I hope you are ready. Are you?
Yes.
Yes. You're going to get your time.
I'm very, very pro equipping nurses to do it right.
Okay. Yeah, I'm so happy to have you today here. I don't know if we have any questions for her.
I mean, we would like to know, like the future of infusion therapy.
Yeah.
Like how do you see it in the future? How does it change the healthcare?
So that's an interesting question. So I think, for instance, biological agents that we do intravenously for autoimmune diseases, a lot of those are changing from infusion to the patient self-administering subcutaneous.
Okay.
So that actually may become less because modern medicine evolves
Okay.
You can now take a tablet or inject yourself.
Yes.
So the actual infusion side of it may become less. I don't know. It's going to take years, but it may get there.
I don't think I want to agree with you on that one. But
no, I really do. If you speak to any of the rheumatologists, endocrinologists, they'll tell you. Iron, probably not. Iron will always, there are iron tablets that don't work. We get it intravenous. That's one of the things. Okay. But the other thing to consider is that if NHI comes in, the hospitals are going to get busy.
Yeah.
People are going to want to have the choice to do something that can be managed at home or at a facility like mine to rather do that.
Yeah.
It is going to happen.
Yeah.
And I think that's where the private nurse practitioner needs to position herself.
Yeah.
Is there that you can provide the service for an overburdened hospital.
But then they can only do what she's saying today if you have a practice number. If you are a sister, you are an RN, and you're still thinking you don't even have a practice number, forget. Jeez. Am I lying, sister?
No, you have to to have a practice number. Yes. Yeah.
So there are a lot of RNs that don't have practice numbers, and I always say, guys,
you can't build the medical aids if you don't have a practice number.
Yeah, and I always say, even if you don't know what to do with it as like now, just have it.
Just have it.
Put it in your pocket.
Yeah.
It will make sense one day.
And also, what is most like? What do you find most rewarding about being a private nurse practitioner?
I do believe, in a small way, I really make a difference in people's lives.
Yeah.
In that hour to 2 hour that they come spend with us, I know my drugs, so I educate them. So again, iron, I will sit there and I'll draw pictures for the patient and I'll explain to them iron deficiency or their biological agent. What part of the inflammatory pathway is this biological agent suppressing?
Yeah.
Why does it suppress your immunity? What is the consequences of that? And so I build relationships. A lot of my patients are not once-off infusions.
Okay.
They come repeatedly.
Yeah.
And that is always a good sign. So somebody may have, for instance, there's a drug we give for osteoporosis. It's a once-a-year infusion. They will come back once a year for their infusion because we've developed that relationship. I know a lot about my patients. I know what their fears are, what their anxieties are, and we really build relationships with our patients. And that is the one thing. I had a patient that we did a drug on for motor neuron disease for 5 years.
What? And medical aid was paying for 5 years?
5 years we did it on him. He's now bedridden. The drug is not working anymore.
Oh,
but we still remain in contact with him.
Yeah.
We send messages to him. He sends messages back to us. And we follow him as his life is now coming to the end. And for me, that's very precious, the relationships we build with our clients. And I always say that in nursing, whenever you have a client walk through your door, they are vulnerable. They're in a bad space.
Need you, yes.
They're coming because they're sick.
Yes.
So you are now offering them a good professional service, but with empathy, with care. It really goes a long way. So I love the relationships I build with my clients. Yes.
Yes. Wow, nice.
Any,
Gay, if you were to advise someone who's sitting at home, who does not know what to do, they want to open a business, they don't know where to start, how can you advise someone who is hopeless, at home? And they've got skills. And I think
it's always important to know.
Like that beautiful lady over there. Yes.
So, well, first of all, what's your passion? But also is to know what is the need within your community. Because sometimes your passion and the need may not align.
Yeah.
Sure.
And you have to decide. So if my passion is not a need in this community, do I need to go set up somewhere else?
Yeah.
Or do I need to start the need? So within that community. So let me give you an example of palliation. So I have a big passion for palliative care nursing.
Okay.
But I'm not at the stage where I can do palliative care nursing.
And it's a big need.
There's a big need.
That's another department that's hushed.
So, but I have good connections in palliation nursing.
Okay.
So when patients, I often get phone calls from somebody who will say, my mother's dying, please can you come and put up a drip? We just want to make her comfortable.
Okay.
And then I'll end up having this long conversation about what is your end goal of us putting up a drip? And often we don't put up a drip. I actually say to them, here's a palliative care nurse. Here's a palliative care facility, or this is hospice number. Call them in. and I talk them through the palliation. So palliation is a passion of mine, but I can't do it at this stage. So I've now developed the connections with people who can do it. So I think always being passionate about what you're doing is really a good start.
But thank you also, Sister Gail, for opening those opportunities, because as NBS, we will be definitely locating those untouched departments in terms of assisting and making sure that we provide those services to the community.
Palliation is a big thing.
And we would will be. I'm happy. She's also partnered with NBS in terms of training, upskilling, empowering.
Wonderful.
So yes. Wonderful. So hence I'm saying from next year we're going to have the trainings aligned with what she provides, that we can send our members to her to empower, to train. Yes. Thank you so much, Mami.
Pleasure.
Thank you.
Thank you, Kate.
And by the way, I'm like surprised that I'm astonished from someone who said this is their first time.
She did well. She must come back.
Well, the winner of the scrubs.
This is the first time we announce our winner. That for the scrubs.
I wish we had them here.
Oh, no. She will still need to be measured. Measurements and proper. Sister Grace will go and do the measurements. But you can do the honor.
Perfect.
Yeah.
What's the name of the lady?
Masala Lavengwa.
Masala Lavengwa.
Yeah.
Beautiful name. Drums to the winner of the first winner of the scrubs competition.
This? Brady, are you recording? I want this as a clip.
Oh yeah, let's do it as a clip. Let's do it as a clip. Drums rolling. To the first winner of our scrubs competition, Masala Lavengwa. Congratulations to you.
Congratulations, Masala.
Yeah,
thank you so much for supporting. This means a lot to us. Continue voting. Even if we've got about 100 pairs of scrubs, we will provide.
Exactly. Don't forget how to be part of the competition, how to join. You need to send 5 of your friends our YouTube link. Get them to subscribe, like, and share, and take a screenshot of them who have subscribed. Send it to us, and you win. Easy as that.
Yeah.
You don't have to do anything else.
Yeah.
You know what I mean?
Yeah, and then please tell them about the 5 tickets again.
Definitely. And we keep on giving away stuff. We keep on giving away stuff. We give you scrubs. After giving you scrubs with the competition, there's another competition on this video. If you are watching this, by the way, the numbers are nice, right?
Yes,
the numbers are nice. Yeah. So you have to make sure that if you're watching this right now and you want to win a ticket to the 8th of November event, Global Nurses Summit event coming up, do put a hashtag there. Hashtag 2nd annual Global Nurses Summit.
Yeah.
Hashtag 2nd annual Global Nurses Summit.
Yeah.
Comment that.
Yeah.
Like and share. That's it.
Yeah.
And you get a ticket.
You get a ticket for free, and then you come. And then in there's a lot of benefits that they will be getting. There's a lot of gifts. We're also going to have a makeup with Tash. Beauty with Tash. Yes, she's going to give us the face bits for free.
Wow.
On that day. Wow. We're doing it all for nurses.
What are we wearing again?
Dress to kill.
Dress to kill.
I don't know, really? Because you are always in your scrubs.
That is true.
This time we dress to kill.
Yeah. So Sister Gail will be there as a speaker, guys. You don't want to miss this informative education and presentation that she will be giving us on that day. Definitely. Please make your way to the 8th of November, the Galleria Center in Sandton. Yeah. Yes, that's where I will be there. So, what else?
I think that's all about it. That's about it right now. Just for now. I think we're going to have a part 1 and part 2. Stay tuned. Don't forget. Follow us, subscribe, like, and get a notepad all the time.
Yeah.
We've got great people with great insights.
Just a recap. If you happen to have some funny cravings, especially by Imana Barina, if you've got some funny cravings where uduma, can you go like a spade? Uduma mu, we call it mu in our language. Please consider that as a sign and symptom of iron deficiency. A sign. of iron deficiency.
Yeah.
And then also the eyes crashing.
Yeah.
Likened to want to eat some
lots
ice.
of iron.
Crush.
Lots of
That is a sign
fatigue.
for
Fatigue
and
is a big
fatigue.
one.
Polaba.
If you've got fatigue, you are craving iron or clay together, you probably definitely got iron deficiency.
Yeah. Okay. So this is another department that we want to support you guys to add into your services that you have already running in your practices. Iron deficiency. Obviously, there's Sister Gail and her company that will assist us to structure and have you ready in terms of equipment, emergency equipment in case you have the whole full package of a training from her. Thank you so much for listening to us today. Yeah, let's do it as nurses.
So
Woo!
Cool.
Okay, we are done.
That's it.
Good.
Yeah.
Perfect.